Hey, what's up everyone, and welcome back to my channel. As promised before, today you're gonna get the unedited, real academic foundation program interview. This is gonna be the whole thing, but broken up into two parts. This first video is the clinical station, and the next video that I'll be releasing next week will be the second part of the interview. In this video, I will show you the exact prompt I was given, explain what happened during the 5-minute reading period, play the full clinical interview unedited as it happened, and then we're going to break it down together. What I did well, what I could have done better, and what a high scoring answer should include. The goal is to give you guys the most realistic picture of what actually happens in an AFP interview so you can prepare confidently. So let's get to it.
Good morning.
Morning. How are you?
Hi, my name's I'm from the Northwest Foundation School, and I'd like to introduce today's interview panel.
Okay.
So if I hand off to them briefly.
Good morning. I'm one of the senior anaesthetic registrars working in Liverpool.
Okay.
Hi, I'm a psychiatrist, so I'm working in Blackpool.
Okay. My name is Hafsa, if you guys don't know. I'm a medical student.
Okay, so first thing, can I just check your identification, please?
Yes. Sure. Here you go. Can you read it?
Perfect, thank you. And then, if possible, can you just move your webcam around just so there's no one else in the room?
Hold on, I'm attached to... Okay, there you go.
Yeah, that's absolutely fine.
Okay.
And finally, can I just ensure that you've got your mobile phone switched off for the interview?
Sorry, I've just got my
Or just
iPad
on
next
silent,
to you.
but just so there's no distractions
Okay.
and things.
Yeah, sure. I'm just gonna shut this way. There you go.
Okay, so the interview will be 30 minutes long,
Okay.
comprising of 2 interview stations. I'll be using the digital hand raising signal at 14 minutes of the first section, and then the 15 minutes, and then again for the second section there'll be a digital hand with 1 minute remaining, and again at the end. If you do want to move on before the 15 minutes, then obviously I won't require to raise the hand, and you can just move on to the next section if you've finished your answer for that section. Do you have any questions for us?
No, that's all good.
Okay, so for the first section I'll be sharing a scenario on the screen. You'll have 5 minutes to read it, and then I'll remove it from the screen so you can talk to the panel members. Okay, so if you're ready to start, I'll share my screen now for the first section.
Yep, ready to start, thank you.
Okay, bear with me 1 second. Okay, can you see that?
Yep.
Okay, I'll hand you over to the panel now.
Can I begin?
So if you just take the full 5 minutes, you go about another minute, and then we'll ask the questions.
All right, thank you.
Right, so we're just coming up to the end of those 5 minutes. So we've got 10 minutes now where we're just going to ask you 3 questions based on that scenario, if that's all right.
Yeah, that's fine.
So you're happy? Happy to start?
Yep.
So what are your key issues in the immediate management of this woman?
So she appears to be acutely unwell. The main thing I reckon is that her blood pressure is quite low and her heart rate was so her blood pressure was 80/50 and her heart rate was 160, which makes me think that, made me think that she was acutely unwell, and that's the first thing that I have to deal with. Apart from that, based on the scenario, it looked like she had an obstruction because of the bilious vomiting. So I'd probably call my registrar and I would probably stabilize her so that she is available for a surgery. The last thing that I noticed was that she had an appendectomy scar which was tender. It wasn't there wasn't any sign of peritonitis based on the clinical exam, so there was no rebound tenderness or guiding. But the fact that her abdominal scar was tender makes me think I want to perform some additional investigations, possibly a chest X-ray, just to eliminate any chances of peritonitis.
Okay, so how would you very basically approach her?
So I
would seeing her in A&E.
Yeah, so I would follow the ABCDE approach. So I would initially start with looking at the patient, speaking to her. If I see that she can speak, that means her airway's clear. Then I'll listen to her chest sounds. Then I'll move on to breathing. Her oxygen stats were 99%, which was pretty good. But then I'll check her respiratory rate after that. Then I'll move on to C. I will put the IV bore axis. I'll check her ABGs. Then I'll move on to D, check her GCS. I'll check her glucose values, and especially because it mentions her breath was alcoholic, so she might need some thiamine because of that. Finally, I'll look at her exposure once again and temperature. And because her circulation was, because her blood pressure was really low, I'm going to give her IV saline, and I'm going to keep checking to see if she's responsive to the saline that I've given her. And
okay.
I also call my registrar. Yeah.
All I was saying, is there any idea how much and how quickly you might want to give some?
So I'd give her 500 mils of normal saline, and I'd give it to her. I'd give a bolus initially, and then I would give it to her over an hour.
Okay, fine. So what investigations would you like to do?
First thing I would like to do is a chest X-ray once she's stabilized, and I would also perform an ABG to check her pH levels, to check her bicarb, oxygen and carbon dioxide. And then I think from there I'll check the results and I'll see what happens next.
Okay, fine. How might you be able to find a bit more information about it?
If she's got someone with her, I would ask for collateral history. If not, I might look into the system, see if there's something about her, if she's come into the hospital before. And if not that, once she's stable, I'm going to try to get a history from her as soon as possible.
Okay, so we're going to show you some blood results now.
Okay.
And I'd just like you to have a little look at these blood results. So alongside the blood results, her temperature is normal and her GCS is about 13. So can you have a little look at the blood results for me and just tell me what are the key abnormalities and what should you do about them?
Okay.
It's all right if you want to work through them one by one.
Okay. So her hemoglobin is it's normal. Her white cell count is high. Apart from that, MCV is normal. CIP is also high.
And if you find any abnormalities, try and hazard a guess as to why they might be.
Okay. Okay, her urea and creatinine, they're high. I'm assuming because she's her blood pressure is low, she probably could be hypovolemic, so that's one of the reasons for it. Her white cell count is high. She could be having an infection. She recently had a surgery, so it could be possible. And her CRP is high, so something like that could be happening. Apart from that, her amylase is extremely high. she could be having pancreatitis.
Okay.
Yeah.
What do you think about the blood alcohol level?
I'm not sure, to be honest. I think it's high. I'd have to check the values. Normal.
Okay.
Mm-hmm.
No problem. So you said before some other investigations. So these are the blood tests. You mentioned an X-ray. Are there any other imaging we could do? Any other forms of imaging we could do?
I think an endoscopy as well, just to check if she's got, she was, sorry, I'm going to take a second.
It's all right.
So she had...
So you mentioned to me about the amylase, and you mentioned she might have pancreatitis, so what scans could you do?
I'm thinking HIDA scan. Why am I thinking HIDA scan? I'll perform a CT scan as well once she's stable.
Okay.
Mm-hmm.
Okay. So if you were really thinking about pancreatitis, what other bits of information from her history you might you want to know about? Just thinking about the potential causes.
So with pancreatitis, the two main causes would be alcohol, gallstones, followed by triglycerides. So I would want to check her triglyceride and LDL levels, the blood alcohol level you did give me. And in terms of gallstones, I'd also check if there's because she had bilious vomiting, so there is a high chance that she could have had an obstruction because of the gallstone. So hopefully it'll show on the X-ray. If it doesn't show on the X-ray, then we'd have to move her on and check HIDA scans or an ERCP. Can you hear me?
Yeah,
The screen.
fine. So you've given me an answer. Yeah.
Okay.
It did break up a bit, but
Yeah.
we're back. So you just told me what you think some problems might be in some investigations. So you're going to need a bit of senior support with this patient.
Yes.
I think that would be sensible.
Yeah.
So you said that before. What sort of teams would you be referring this patient to?
I would contact the surgical team, because if there's an instruction, they might need to deal with that. And she might need to be intubated, so the anesthesiologist. Apart from that, the senior registrar I've mentioned before that I'd have to contact, and that's all I can think of at the moment.
Okay, so it's probably not an uncommon situation. So frustratingly, the surgical team don't want to see her.
Okay.
And the medical team are saying that they don't want to see it. So what realistically would you do in that scenario? If you'd rang the surgeons, rang the medical team, and they didn't want to take this patient?
I'd continue to stabilize her and try to find out more about her in terms of the medical history. I'd try to find out more, more of the values, more scans, and then I think I'll contact them again saying, look, I think this patient needs urgent care. Can you try to see her again? And I've got some more values for you guys to help you out.
Okay. So who else could you speak to if they were continuing to be stubborn?
I'd have to escalate it, so I'd have to speak to the supervisor in charge.
Okay, fine. So do you know any potential sort of pathways or things you could find on your hospital intranet about how to manage pancreatitis?
I think it's on the, I forgot what they call it. I know that every deanery has a trust that you can access the information about what to do in each case, and you have information about drugs to give and and who to contact and stuff. Yeah,
so you'll be able to find them, as you say, on the hospital internet. So we've got probably another 30 seconds or so for this section.
Okay.
So if we just go back to the investigations very quickly,
Okay.
You mentioned you're going to do a CT, you mentioned you're going to do an X-ray.
Mm-hmm.
If you were worried about gallstones, what other scan could you potentially do to try to look at some gallstones, which could also look at the pancreas as well?
MRCP.
Something much simpler?
An ultrasound, yeah.
Okay, perfect. Right, so if you've not got anything else that we can add to that, then I think We finished just about the 15 minutes.
Okay, so let's break it down. The main things this station is testing are recognition of an unwell patient, a structured approach, especially ABCDE, safe initial management, sepsis recognition, appropriate investigations, escalation to senior help, your ability to prioritize. What they're looking for is not for clever diagnosis. They just want to know that you are safe to work as an FY1. And that's the market that they mark highest. The logic behind it is you don't get as much clinical time because you also balance it with academia, and they need to know that you have the foundations to become an excellent FY1 doctor. So what I did well here was that I recognized straight away that she was acutely unwell. I attempted to use an ABCDE approach. I discussed fluids and calling seniors. I considered diagnoses like obstruction and pancreatitis. I mentioned collateral history. So in general, my clinical intuition was correct. Okay, let's go through every single question they've asked me and how I should have answered these questions. So number one, what are the key issues in the immediate management of this woman? So this patient is critically unwell with shock, blood pressure is 80/50 and the heart rate's 160. My immediate priorities are ensuring an airways patent. So I'm literally following the ABCDE assessment. Ensuring an airways patent, assessing the respiratory rate, oxygen sats and giving oxygen if needed. Shock management, so 2 large bore IV access, bloods including lactate, cultures, group and save, fluid resuscitation, 500 mils of crystalloid bolus. So that you can also say normal saline, you can also say lactated ringers. You can also mention that you're worried about this person's heart, so you're going conservative with the fluid management. We're placing a urinary catheter to have an accurate measurement of the ins and outs. We're considering an EKG. And then for disability, it's the GCS plus glucose. And then exposure, we also mentioned the full abdominal exam. So the sepsis 6, the logic behind it is tachycardia, hypotension, and the elevated white count and the CRP, which you'll see in a bit. And then senior support, we want to get them involved early. You can mention surgery or anesthesia. And we're keeping the patient nil by mouth, given they could go to the OR. And we're considering an NG tube if they're vomiting. Where I made the mistake was I recognized the shock, but I didn't explicitly mention the sepsis 6. I did not mention the catheter and urinary output, which was an easy one. And I jumped really quickly to the obstruction and surgery rather than prioritizing the stabilization, which is the main thing that we do like literally all the time. And this is me talking to you guys from a now I'm a doctor perspective, and now I see this with open eyes. Question 2 was the basic approach. So as I mentioned, it is the ABCDE from above. The key details here was really like the shock pathway and the inserting 2 large bore IVs, sending bloods, so a full blood count or a complete blood count, whatever you want to call it, UNE, or if you're in America, it would be BMP, LFT, CRP, amylase, lactate, and cultures. We're giving the 500 mil blood, we're giving the 500 mil crystalloids. We're reassessing after every step. Any intervention that you perform, you want to reassess. We're putting the catheter for urinary output. We're giving the analgesia. We're giving the antiemetic. We're keeping nil by mouth. We're considering putting an NG tube in and early senior help. I did use the ABCDE. I didn't clearly outline it. I could have done a better job. I recognized the low blood pressure. Initial investigation, so urgent bloods. So it's all the stuff, the good stuff that I mentioned. We want to get complete blood count. We want to get BMP, LFTs, the whole shebang. The CT abdomen with contrast is one stable. The right upper quadrant ultrasound, we want to do it if there's a biliary cause that we're suspecting. I said a chest x-ray, which isn't wrong, but that's if we're concerned of a perforation, but it's lower priority at the moment. And the endoscopy was a no-no. How to find out more information. The model answer would have been collateral from family and paramedics reviewing past records. So if they had like elevated T-bili, if they had elevated triglycerides, we kind of can tell that. But main causes would be alcoholic pancreatitis or gallstone panc. And then a focus history when stable, and then we ask all the systems in questions. My answer was correct. The blood results interpretation. So I gave you guys a sample up here, but they literally give you a set of labs and you need to know the normal values. We had the elevated white count, elevated CRP, so we're thinking inflammation or sepsis. We have the elevated urea and creatinine, so an acute kidney injury, probably pre-renal because of the hypovolemia and septic situation. We have the elevated amylase, which is screaming pancreatitis to us. And we're assessing the LFTs and bilirubin because we want to identify the cause of the pancreatitis. So the actions based on what we see is continue the aggressive fluid resuscitation. We want to monitor urine output. We want to escalate early. We want to give analgesia. Where I deferred, I had a reasonable interpretation, but I wasn't sure about the bilirubin. And in this case, it was normal. And it can also happen with biliary pancreatitis, like gallstone panc. It can definitely happen if you pass a gallstone, you'll have downtrending LFTs. So it wouldn't be completely unreasonable to have that. Some people stay at home until it becomes like raging abdominal pain that they can't tolerate. So, and if you are trending it, you will see a downtrending bilirubin, and then sometimes it could also be normal and the person comes in with pancreatitis and it's close to like resolving. So this wouldn't be like completely insane. Other imaging modalities. So we mentioned above, it would be CT abdomen with contrast when stable, and right upper quadrant ultrasound to figure out what the cause could be. And to be honest, more than the CT abdomen with pelvis, that's more sensitive for the common bile duct. I would want the right upper quadrant ultrasound to check for cholelithiasis, especially in the setting of a normal T-bili. And then it would be the CT abdomen. I mentioned an MRCP. It could be considered, but later if biliary obstruction is suspected. A HIDA scan would not be indicated. You do a HIDA scan when findings are equivocal. So if the ultrasound isn't screaming acute cholecystitis, then you would do a HIDA scan. I initially mentioned an endoscopy, but this wouldn't be appropriate. Sometimes people get nervous and say incorrect things, which was what happened to me. Additional history for suspected pancreatitis. So I would want an alcohol history, a gallstone history, lipids or triglycerides, medication history, any prior episodes, family history, and as always, surgical history for a surgery consult. I mentioned the alcohol, gallstones, and triglycerides, which was good. I added the LDLs, not needed at this time. It's kind of, the triglycerides are a less common cause, and I mentioned the HIDA, ERCP, but this is too advanced at this point. So an ERCP, you would jump to that if the patient is cholangitic, which they did not give me any indication of like altered mental state or anything that would lead me to think about cholangitis. And I mentioned to you guys about the HIDA scan and when it would be indicated. Then the next question is who to involve or escalate it to. So the right answer is a surgical registrar, anesthesia, ICU, and a medical team if it's unclear what is going on. I mentioned surgery and anesthesia, which was great. Next, if surgical or medical teams both decline to accept the patient, what would you do? So you continue resuscitation and monitoring. Your priority is to get this patient through the storm. We represent the clinical findings and imaging as we get more findings. And then if they still say no, we escalate to an on-call consultant. We inform the site manager or duty manager, and then consider the ICU outreach. And as always, you document everything to cover your base and also to not forget anything, because as things are happening real time, you know what's going on, but later on it's a little bit harder to document exactly word for word what happened. So my answer, the escalation was appropriate, but I didn't really mention the site manager or duty manager, and I could have done better with that. Next, they asked me about guidelines or pathways for pancreatitis. I did good. I had like the right awareness, but not the right wording. We trust the clinical guidelines that are available on the internet, and the management is supportive. So it's IV fluids, analgesia, oxygen, and monitoring for complications. We want to get them through the pancreatitis storm, even if it's gallstone panc, that's the cause. You want to remove the gallbladder, but you want to do it during the same admission once the pancreatitis has resolved, because that inflammation is not a great scenario to operate in. Then they asked me about a gallstone related scan. The correct answer is a right upper quadrant ultrasound. That is the most sensitive for cholelithiasis, so gallstones within the gallbladder. But a CT scan is the most sensitive for common bile duct dilation. I did initially say MRCP, but then I did correct it to the ultrasound. So guys, this is the clinical station breakdown for you. I hope this helps you understand how to structure a station, how to think about it systematically, and how the panelists look at your answers. In the next video, I'm going to go through the second part of my interview, which is the academic station, what they asked me, how I answered it, and how I would improve my response. If you find this helpful, please like, subscribe, and leave your questions below, and I will see you next time.